Hi, good afternoon. So while the hall was just completely full a little while ago, we'll be talking almost similar thing, but maybe we'll be skinning the cat in a different manner so that you have learned different options. So my talk is on management of subluxated lens, anterior or posterior approach. So in the era when we used to do intracapsular cataract extraction, we had no problems. The lens was there, we had to take it out, no IOL was to be inserted, and there was no confusion at all. But in the IOL era, we have had problems because the lens could be subluxated, could be dislocated, and you could do it by different techniques. So I'll be dealing with the causes, the clinical evaluation, how do you plan the intervention, and a few cases. So you can have, the causes could be a congenitally subluxated or dislocated lens, which can be because of Marfan's, Weil Marchesani, homocystinuria, Ehlers-Danlos, congenital aniridia, colobum of the lens, and many other uncommon causes, but they can cause this. Then you can have it because of trauma, or it can be iatrogenic, and you can have it a condition which is fairly becoming well recognized as pseudoexfoliation, a hypermature cataract, high myopia, and retinitis pigmentosa. When you decide to evaluate such a patient, you must obviously take a good history where you want to evaluate what could be the possible cause for the subluxation, must do a good systemic examination to rule out any associated problems like a cardiovascular issue which may be associated with a subluxated lens. And when you do an ocular examination, look for pseudoexfoliation, retinitis pigmentosa, any history of trauma and associated trauma to the anterior and posterior segment, like an angle recession, an iris damage where your pupil might have become atonic, the intraocular pressure, you may have a secondary glaucoma, the endothelial cell count because you will have to decide when not to put in a lens, then evidence of any retinal pathology like a retinal tear, a dialysis, vitreous hemorrhage, or a macular hole. Now, when we examine the patient, we look for the extent of subluxation. When you look for the extent of subluxation, it could be mild when the subluxation is just 90 degrees. It could be moderate when it is about 90 to 180 degrees, or it could be more than 180 degrees because this eventually has implications for your surgical management. You look for the extent of zonular damage. You look at the lens borders because a careful look at the lens borders will tell you what is the pathology of the zonules adjacent to them. Look at the anterior capsule if there's a fibrous plaque because that is important when you're doing a rhexis. And you look for the chamber depth, whether the chamber is deep, and especially you must make the patient lie down because when the patient is lying down and the lens goes backwards, then it is not possible to do a phaco. In this patient, you have to do a vitreous surgery with a lensectomy or a phacofragmentation. Now, there can be sometimes subtle signs of subluxation like a phacodonosis, you can have a focal iridodonosis, and you could have an irido-lenticular gap, or you ask the patient to look to the edge, you can see a lens edge on one side. Now, for example, here you can see there can be a localized focal blunt trauma, and you can have pseudo-exfoliation on the zonules, which when once documented, you know that the zonules are weak. And once the lens edge you see, if it is flat, it means the adjacent zonules are strong. If the lens edge is rounded, you know the zonules are weak, and this is a very small little observation which is important. Now, defining the extent of subluxation will decide what approach you take. If it is a mild or a moderate subluxation, it could be predominantly an anterior approach. If it is a severe subluxation, you can predominantly do a posterior. Approach where you will have to use assistance of a vitreous surgeon and a phacosurgeon or a surgeon who is capable of doing both. Now, there are various devices that are available that assist you, and all of you know it. You can have a capsular hook, you have a capsular tension ring, you have a capsular tension segment which can be fixated, and you have a Sionis ring which is a right-sided, left-sided, or it could be, you can have a fixation spot on both the sides. The capsule can be supported by iris hooks, or it can be supported by special hooks which actually support it at the equator rather than supporting it at the capsular edge, because that prevents any damage to the capsular edge. Then there are other things described in literature, which Susan Jacob has also described, and you have an Assis anchor paperclip hook and various other techniques which you can use to support the capsular bag. The key to anterior approach is a good capsular rhexis. You should try in such a situation to make a rhexis which is not too big. This is challenging. You should use the capsular staining, and you should ensure that the edge is about 2 millimeters from the equator so that you can have a good anterior leaf for your capsular tension ring. You can either do it with a capsular forceps or you can do it with a cystitome, and you should initiate the rhexis, and this is important, initiate the rhexis in the direction of where you are having the subluxation, because your counter traction is by the intact zonules, and if you initiate it in the opposite way, you'll be actually increasing the subluxation, and that can be avoided. You could either do it in a patient with, you can do it with you can either do it with a, so in such a situation, a femtosecond laser-assisted capsular rhexis is a good idea, or you could actually do it with a zeptorhexis, which would again help you in getting a better rhexis in place. So this is, for example, a zepto being done on a subluxation. I will, because this course is short, you can see how the zepto is so useful. You just go inside. It's a disposable system. You can get your rhexis done, and then the usual subsequent steps of managing a subluxated cataract work. Now, in phacoemulsification, the good important points are your hydrodissection must be very good. In a young patient, you may just manage to get it over with an IA alone. You must use replenish the capsular fornices with a dispersive OVD and over the hyaloid face. If there is a vitreous prolapsing out, anterior vitrectomy is a must, and I'll show you some videos to show that. Ideally, you should do a stripping of the cortex in a centrifugal manner rather than a centripetal manner, which may be a little difficult, but once you start practicing it, it becomes easy. A tangential stripping towards the area of missing zonules will help so that you don't cause any traction on the zonules. Now, there are certain tricks for placing the CTR. It helps to stabilize the bag. The CTR may trap the cortical matter, so you should try to insert the CTR as late as you can, but as early as you must. And this is a very important statement which was made by Ken Rosenthal, so that you don't trap a lot of cortical matter behind. You should have removed as much cortical matter as possible and still be able to stabilize the bag. Which CTR to use? This you have to decide based upon the extent of subluxation, and as I showed you, you can have a CTR, you can have a segment, or you can use a combination of a CTR and a segment, or you could use a Sionese, which is stabilized with ninoproline sutures, or with Gore-Tex sutures, which are being used, though Gore-Tex is a little thicker to use. But if there is a PC tear, you should not use the CTR. Then best is to put in a lens on the rhexis or do a sutured IOL. Which IOL you have to choose? Ideally a 3-piece lens. Rarely you can use a single piece IOL. It's better not to use a multifocal IOL in this situation, even if there is a stress upon you to use a multifocal. Toric IOLs can be used if the dialysis is small, and in case of PC tear, try to use a sulcus fixed IOL, a scleral fixated IOL, and maybe even an AC IOL. Now, regarding the vitreous management, the vitrectomy should be done in assistance with triamcinolone. It should be a bimanual vitrectomy, and you should be able to complete the vitrectomy from pars plana at the end of the surgery if required. This is just a small little example of the vitrectomy being done. So you have the triamcinolone is used, and you can see here the vitreous knuckle is coming out. You go ahead and stain it with triamcinolone. You can do the vitrectomy as much as possible, and once the vitrectomy is done, then the remaining steps for phaco work, and you must be, this triamcinolone makes the things extremely easy. Now, this is a small little video which I think in the last session they showed that you have to do a lancectomy for such a patient. This was my partner who did we went ahead and did a vitrectomy, and we put in a Sionese ring, we put in a capsule and a small segment. We did a zeptorhexis, and then we went ahead. This is after the vitrectomy. We went ahead and we got a rhexis right, and after that we did a phacoemulsification. I could not believe that in such an amount of subluxation we ended up placing the lens within the bag with the Sionese ring sutured, and just show you the ending of this surgery. So you can see here the bag is well inflated, and subsequently we put in the lens and we were able to get the, so every case like this, you don't have to do a lensectomy and do a glued IOL. You can see a beautifully placed IOL, and you don't have to do a glued IOL. If you can stabilize the bag like that, it works pretty well. So the take-home message is, if you have a mild subluxation, and if it is not a progressive zonulopathy, you can do an anterior approach, taking support by CTR, capsular hooks, and Sionese. If you had a moderate subluxation, then of course Sionese, CTR, and the CTA segment can be used, and IOL can be placed in the bag. But if you have a severe subluxation, you can either do as I showed you in the last case, or you could do a lensectomy or a phacofrag if it is dislocated, and you can visually rehabilitate the patient either with contact lenses, or an EC-IOL, or an iris fixated lens, which can be anterior or posterior, or a scleral fixated IOL, which could be sutured, glued, or an SF-IOL done with the Yamana's technique. And thank you, Dr. Sindel, for this opportunity. Thank you very much.